Good morning, good afternoon, and good evening, philosophers, and welcome to episode possibly 11 of our course on philosophy of science through the lens of medicine. Okay, so today we're going to be looking at evidence-based public health. Imagine a government minister announcing a new public health policy with great confidence. The evidence is clear, we must act immediately. That's excellent and reassuring and kind of science-shaped, But then someone asks, clear evidence of what exactly? That the policy worked somewhere, that it will work here, or that it will work here for these people under these conditions without causing a small economic collapse. And suddenly, follow the science starts to look less like a slogan and more like the beginning of some difficult homework. Today, I want to explain evidence-based public health, how it differs from evidence-based medicine, and why social media reports might, used carefully, help policymakers understand the contextual conditions that determine whether policy will actually work. So let's begin by returning briefly to EBM. EBM, as we talked about in the last video, developed partly as a rebellion against medical paternalism, the idea that a senior doctor's confident opinion, perhaps delivered over a cigar and a large desk, should settle what happens to patients. Its central claim is sensible, that clinical decisions should be based on the best available evidence rather than intuition, tradition, personal experience, or an attractive theory about how a treatment ought to work. Traditionally, EBM places randomized controlled trials, or RCTs, near the top of its evidence hierarchy. In an RCT, patients are randomly assigned to receive a treatment or a comparison, often a placebo. Randomization helps ensure that differences in outcomes are very likely to result from the intervention itself, rather than from some pre-existing differences between the groups. That's really valuable. Medicine has a long and rather embarrassing history of treatments that seemed perfectly plausible but turned out to be completely useless, or worse. Bloodletting was not improved by the confidence of the person holding the leech. But EBM has limitations. You can't easily blind people to whether they've undergone surgery, started exercising, or spent 3 months attending mindfulness classes. This creates what's been called a pill bias. Treatments that resemble pills are often easier to test in classic RCTs than social, behavioral, or environmental interventions. There's also a problem of specificity. A trial may show that a drug works on average in a carefully selected group in one country, but will it work equally well for a pregnant person, an older patient, someone with multiple chronic conditions, or a population living in very different social and economic settings? The trial may establish that something can work, but it doesn't automatically establish that it will work for everyone, everywhere. Now, evidence-based public health, or EBPH, shares EBM's basic ambition. Public decisions should not rest just on political instinct, ideological enthusiasm, or the fact that someone has printed a very persuasive infographic. But the object of decision-making is different. EBM is principally concerned with decisions about individual patients. A doctor talking to a patient. Should this person receive this treatment? EBPH concerns communities and populations. How should we prevent disease, protect health, reduce risk, and improve the conditions in which people can flourish? That means public health interventions are often not neat, uniform objects. A tablet is relatively stable. It's the same tablet whether you take it in Johannesburg in California, or a very disappointing airport lounge. But consider a campaign to increase vaccine uptake, reduce smoking, improve nutrition, or encourage HIV testing. Its effects depend on trust, language, poverty, access to clinics, family structures, religious beliefs, transport, media habits, local histories, and whether people have good reason to distrust the institution delivering the message. In EBPH, evidence is therefore often described in 3 broad categories. First, there is evidence that tells us that a problem exists and is important. Smoking causes lung cancer, for example, or a particular community has low immunization coverage. Second, there's evidence that tells us which interventions tend to make a difference. Taxation, advertising restrictions, community outreach, mobile clinics, or targeted vaccination campaigns. Third, and this is the neglected hero of the story, there is evidence about implementation and context. It tells us how an intervention was received, what conditions enabled it, and what got in its way. The first two categories tell us that something should be done, and perhaps what should be done. The third helps us answer the much harder question, how can this be done right here? Nancy Cartwright's work gives us a useful way to understand this. The relevant question isn't simply, did this policy work somewhere? It is, will this policy work in this particular setting? A nutrition program may succeed in one region because mothers control household food allocation, supplementary food genuinely supplements children's diets, and health education is trusted. Transfer the same program elsewhere, and those conditions may not hold. Food may be redistributed within the household. Mothers may not be the principal decision makers. The message may not reach the people who need it. The program has not become irrational. Its causal mechanism has encountered different conditions. Public health policy, then, needs a theory of change, a careful account of how an intervention is supposed to produce its outcome step by step. For a vaccine campaign, the rough chain might be reliable information reaches people, trusted figures communicate it, fears are addressed, clinics are accessible, people are able to take time off work, and vaccination then becomes a realistic choice. If one link fails, the whole policy may falter. No number of elegant posters can compensate for a clinic with no staff, no vaccines, or a queue that requires missing a day's income. This is where social media reports may become useful. To be clear, a spike in posts saying, "I don't trust this vaccine," is not direct evidence that vaccine uptake has fallen. A trending hashtag is not a national survey, and a viral video is certainly not an RCT, however many people add a syringe emoji beneath it. Social media data are biased, incomplete, vulnerable to manipulation, and unrepresentative of people without reliable internet access. They also raise serious privacy and governance concerns, so they must not become a surveillance fantasy dressed up as public health. But, used ethically and alongside other evidence, social media reports may provide valuable evidence about what's happening inside a local causal process. They can function as early warnings. Perhaps a specific rumor is spreading rapidly through channels used by a target community. They can identify possible derailers, mistrust of a government agency, fear of side effects, misinformation promoted by an influential local figure, or a mismatch between official messaging and the language people actually use. They can also reveal missing support conditions. If policymakers are relying on radio announcements while online discussion is happening almost entirely on TikTok, WhatsApp, or community Facebook groups, the intended communication mechanism is not properly connected to its audience. The appropriate response isn't Twitter says we have proved the policy failed. It's this evidence suggests that a part of our local theory of change may be breaking down. Let's investigate, triangulate with surveys, clinical data, community engagement, and public health surveillance, and adapt. Evidence-based public health isn't simply EBM applied to bigger groups of people. It requires broader evidential imagination. It still values rigor. It still warns us against acting on prejudice, intuition, or ministerial vibes. But it also recognizes that policies work through complex social systems and that the relevant contextual conditions vary dramatically between populations. The future role of social media reports is therefore not to replace robust outcome data, it's to help us see earlier and more clearly whether the mechanisms on which a policy depends are actually functioning in the world. Good public health policy should not ask only what worked, it should ask what is happening here and what must be true for this to work for us. Thank you for listening. Please like and subscribe, and I'll see you on the next one.